ಅದಕ್ಕೆ ನಾನು ಸ್ವಾಗತ ಮೇಲ್ ಹೇಳೋದು ನಮ್ಮ ಕರ್ನಾಟಕ ಶಾಖೆಯ ಅಧ್ಯಕ್ಷರಾದ ಡಾಕ್ಟರ್ ರಾಜಗೋಪಾಲ್ ಶೆಣೈರವರಿಗೆ ಹೃತ್ಪೂರ್ವಕ ಸ್ವಾಗತವನ್ನು ಬಯಸ್ತೇನೆ. ಸ್ವಲ್ಪ ಕನ್ನಡದಲ್ಲಿ ಮಾತಾಡೋಣ ಅಂತ ಅನ್ನಿಸ್ತು ಇವತ್ತು, ಅದಕ್ಕೆ ಮಧ್ಯದಲ್ಲಿ ಸ್ವಲ್ಪ ಸರ್ ಮುಂದುವರಿಸಿ ಸರ್.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. Thank you very much for every one of you who have come here. And firstly, my thanks to Dr. Kalaivani and Dr. Arun Kumar, who have agreed for this as examiners, and Dr. Shilpa for moderating this function. I also welcome each one of you to this program. Without wasting much time, I would like to take only 1 minute here to welcome our National President-elect for the next year, Dr. Maruthu Pandian sir. Welcome for this our program. I just want to say only 2 lines here. Every month, second Thursday, 8 p.m. onwards is our PG time. We call it as a PG clinics. It's a second Thursday of every month. And fourth Thursday is a surgeon's time, 4th Thursday. So today is our second PG clinics. We had one in month of March. I also see Dr. Siddesh joining here, Dr. Shivaram just joined, and all others. Sir, Dr. Maruthu Pandian sir, just say a few words for this program. Thank you, sir.
Yes, sir. Yes, sir. Good evening, all of you. I am really happy to participate in this program, an academic program, that too under the chairmanship of Dr. Rajgopal Sinai, my good friend and well-wisher. I could see Dr. Kalaivani, the State Executive Committee member and my good friend, and Dr. GC member, Dr. H.V. Sevram sir, and my mentor and well-wisher, Dr. Siddesh, our academic, Social Welfare Council director, and the Sarvesh Kumar, the secretary of KCASI. So really it is an opportunity for me to be with you for a few minutes, because I've got a case in another 30 minutes. For the past few years, I could see Karnataka chapter is doing vibrant work, not only in academics, but also in social welfare activities. Keep this good work going on. My best wishes to this academic program. Thank you all for the opportunity. Thank you, sir. All the best, sir.
Yeah, shall we start now? Dr. Shilpa, please take over.
Yes, sir. Good evening, everyone. At the outset, I would like to thank our chairperson, KCSI, Dr. Rajgopal Shenoy, and Secretary Dr. Sarvesh sir for giving me an opportunity to moderate the PG clinic presentation today. I welcome our esteemed and respected examiners of today's PG presentation, Dr. Kalaivani V, Professor and Unit Chief, Department of General Surgery, Saptagiri Institute of Medical Sciences, Bengaluru, and Dr. Arun Kumar N, Ex-HOD and Professor and Unit Chief of Department of General Surgery, St. Martha's Hospital, Bengaluru. I also welcome our postgraduates, Dr. Chetana S and Dr. Akhil Gupta. Both are postgraduates in KMCRI, Hubballi. So without much ado, I would like to welcome Dr. Chetana S to present her case presentation, a case of neck swelling. Dr. Chetana, you can start sharing your slides, please.
I request every one of you to keep yourself mute. And if you have any queries, especially postgraduates and all, please put it in the chat box and Dr. Shilpa will take it. So my sincere request to all of you to keep yourself muted. Thank you. Go ahead, Dr. Chetana.
Good evening, everyone. Today, on swelling in the left side of the neck under the guidance of Dr. Shilpa H and Dr. Gurushatnappa Elagachan. Myself, Dr. Chetana, postgraduate student. Here is a 62-year-old male presented with neck since 2 years. A patient was apparently asymptomatic ago. He noticed in left side of the neck, which was insidious in onset, gradually progressed from the initial size of 2 × 2 centimeter to the current size of 6 × 5 centimeter. He also complains of the pain in the swelling since 2 months, which is continuous, dull aching type of pain, non-radiating, which reduces on taking medication. Patient has underwent a surgery over the left side of the neck 15 days ago in our hospital. For similar swelling of size 3x2 centimeter, and specimen was sent for examination. No complaints of evening rise of temperature, night sweats, no complaints of weight loss, no complaints of difficulty in speech, no complaints of change in voice, no complaints of stridor, no complaints of nasal bleed and nasal congestion, no history of ear pain, no history of chronic ulcer in the oral cavity, no complaints of difficulty in opening mouth, no history of abdominal distension, no history of hemoptysis, cough with expectoration, no history of swelling elsewhere in the body. Coming to the past history, not a known case of diabetes mellitus type 2, hypertension and asthma, no history of tuberculosis, no history of previous hospital admission, and no history of irradiation to head and neck. Cancer-related death in their family, no history of tuberculosis in family members. Personal history, appetite is adequate, sleep is sound, bowel and bladder habits are regular. Patient consumes alcohol since 30 years, last binge 1 month ago. He chews tobacco since 30 years and stopped 8 years ago. No history of contact with the tuberculosis patient. Here is a 62-year-old male, came with complaint of progressive increasing swelling in the lateral side of the neck with a recent onset of pain, no complaints of weight loss, evening rise of temperature and night sweats.
So at the end of history, Dr. Chetana, what do you think you're dealing with?
Firstly, it could be a TB lymph node, ma'am, or else it can be a secondary, ma'am. But for TB, we can't. There is no evening rise.
Your voice is breaking.
Voice is breaking.
So for 2 years, we can.
Yeah, in between we can't hear you.
Is it clear, ma'am, now?
Yeah.
Hello, ma'am.
Yeah, we can hear you. Then suddenly it goes off.
I think the internet issue.
Actually,
Chetan, for some time you can, you can mute your video, for some time, because maybe it may feel better. Just check that.
Audio is a little bit disturbing. It's not continuous.
That's why, sir, the video off ಮಾಡಿದ್ರೆ sometime they will be able to speak better. Okay, please
Switch
go
off
ahead.
your video, Dr. Chetana. Let us see.
yes, sir.
For 5 minutes, okay?
Yes, sir.
Yeah, continue. So what do you think you're dealing with?
Firstly, I would keep a provisional diagnosis of. We are in India, ma'am.
No, we
TB
can't
is
hear
the
you.
first
Again,
one.
we
We
lost your
can't
voice.
hear you. No, we can't hear you. Your internet seems to be a
Check
problem.
your internet connection.
Yes, ma'am. Now, is it audible, ma'am?
Yes.
Yes.
Continue speaking. Let us see how it comes.
Continue speaking. Continue speaking.
I would keep a diagnosis of TB lymphadenopathy, ma'am. Then I would also keep a diagnosis of malignant lymph node, ma'am. Either primary or else.
Again, your audio is gone, Dr. Chetana.
Now, is it coming, sir?
Comes and goes. I think the internet signals are pretty weak there.
As there is no history of weight loss, evening rise of temperature and night sweats. Apart from that also, because it's a long duration, 2 years duration there, I'll still, as a in India, I would like to keep it a point of first diagnosis as tubercular lymphadenitis, and second, I would like to keep it as malignant lymph node, either primary or else secondary, ma'am.
No, but at the end of history, how sure are you that the swelling is lymph node only? Are you
Because
sure?
it's on
Lymph
the
node only.
left lateral side of the neck, ma'am, and it is of the 2 years of duration. He said he tells it, ma'am.
And also, what
Lipoma.
common swellings in the neck? Common swelling in the neck.
Most commonest swelling is lipoma, sir.
Yeah,
Common
so
swelling
it
in
can
the
be a
neck.
lipoma also, right? How are you so confident? No, it is lymph node only, primary or secondary.
because he also complains of pain in the swelling, ma'am, since 2 months, and also there is a history of some surgery being done, ma'am, for a similar swelling. So it gives a history that there is other more than one swelling is there. So I would keep it a diagnosis of TB and secondaries or primary of the neck, ma'am.
Does it move with the deglutition?
That in the examination part, I'll check, sir.
Sorry, if you mention about the movement with deglutition, in this case, it will be a wrong thing. Why? Because it is farther away
But
from
it's
the
a lateral
look at
side of
lateral
the-
aspect. So when the swelling is in the lateral aspect,
Will
there is
not
no
check it,
question of you mentioning about movement with deglutition. Let us be very clear about it. If you mention, it's a negative marking for you.
Then why did you ask history of, can you just go to the previous 1 or 2 slides? That no history you said.
Yes, ma'am.
Yeah, see in this, you have asked, next. Why did you take history of difficulty in opening the mouth, nasal bleed and nasal congestion?
Nasal bleed and nasal congestion, keeping the secondaries in the neck, ma'am. I have asked for if there are any primaries such as nasal carcinoma, ma'am. Nasopharyngeal carcinoma.
So you're fine in keeping lymph node as one of the options, but you should not straight away go ahead and say this is lymph node only and this could be tuberculosis or malignancy. That's what I was trying to tell. You should always tell at the end of history, probably a lymph node. It can be anything else also. It can be a tumor, it can be a soft tissue tumor, it can be a lipoma, it can be a malignant tumor, it can be anything. Of course, the most common, and I will consider lymph node because it's the most common swelling in the neck. Probably you can tell in that fashion, okay? You should not dogmatically say it is lymph node only. So that's why we asked so many cross questions. Even sir was asking, will it be a thyroid?
Next slide. So many no's are there, madam. Let the next slide, she has written all no.
Yeah.
Let the positive points come first.
You can put one line, no history of all the symptoms related to oral cavity. No history of all the symptoms related to below the oral cavity. No history of 3 lines.
And you also mentioned no history of abdominal distension. What were you trying to infer with that?
Any CA related to the abdomen, sir. Any metastasis that can be there. If it's we don't know in a history level, we don't know if it's in which triangle the lymph node is present.
Madam, in the starting only, you are making us to go into that in malignancy.
Leading us.
You don't lead us aside. You tell the positive points.
See, I would have appreciated if you are suspecting tuberculous lymphadenitis. If you are told probably if it is ascites and that's why you're asking for abdominal distension, a little more justified. Rather than telling a primary malignancy in the abdomen which is presenting as abdominal distension, probably a little less likely possibility. So I don't think you should go into that. And as Dr. Kalaivani was telling, you should probably mention this case is more likely to be a cervical lymphadenitis, probably COX. And why? Because there are multiple swellings. One of the swellings has been removed, and the most common swelling in the neck is a lymph node, and it's in the lateral aspect of the neck. All these make me think of lymph node. And why not a lipoma? Because it's painful and there are multiple. That's the reason why. Okay. I just summed it up for you.
Okay. Proceed.
Can it be a lymphoma?
Yes, sir. It can be a lymphoma as well, sir.
But how do you justify your chief complaints of
that? Because over here there is a history of complaints of pain is also there, sir, since 2 months, and it's a asymptomatic progressive increase in size since 2 years. It's there, sir, and he has also undergone the surgery, sir. That could be a excision biopsy as well, sir, which is usually done for confirmation of the, because by FNAC we can't get to know, sir.
Can go with the rest of the history and examination. Any other questions, sir?
No, she can proceed.
Okay, proceed, ma. Chetana.
Yes, ma'am. Here is a well-built, moderately nourished old man who is conscious and cooperative. No signs of pallor, icterus, cyanosis, clubbing, and pedal edema. ECOG score is 0. Pulse rate 82 beats per minute. BP is 120 by 80. Respiratory rate is 20 cycles per minute. Saturation 98% at room air. Coming to the local examination of the neck. Inspection, solitary ovoid swelling present in the left lower and middle 1/3 of the neck in the posterior triangle, measuring about 6 cross 5 centimeter with well-defined borders and smooth surface. Swelling is extending anteriorly to sternocleidomastoid. Skin over the swelling is normal except at the summit where there is redness. 3 cross 0.5 centimeter noted above the left supraclavicular region. Palpation, no local rise of temperature, tenderness is present. An ovoid swelling present in the left lower and middle 1/3 of the neck in the posterior triangle, measuring of about 6 cross 5 centimeter, superiorly 3 centimeter below the mastoid, inferiorly 3 centimeter above the clavicle, anteriorly abutting the sternocleidomastoid muscle, posteriorly 2 centimeter in front of the trapezius. Swelling is has smooth surface, well-defined border, hard in consistency. Skin is pinchable except at the summit of the swelling where it is non-pinchable. Mobility of the swelling is restricted. No change in swelling on putting the sternocleidomastoid on contraction. Two other ovoid swelling of size 2 cross 1 centimeter, which is non-tender, mobile, firm in consistency, noted 1 centimeter below the previously described swelling, and one in the posterior triangle. Trachea is central, left-sided carotid artery is palpable. No other swelling in the neck, axilla, inguinal region, epitrochlear region, mediastinum. Examination of the oral cavity, mouth opening is adequate. Poor oral hygiene, dental caries are present, few miss.
Chetana, your slides are not getting shared. Please see.
She has gone offline.
Chetana, your slides are not getting shared. Just look into it. Please unmute yourself.
Tonsil and tonsilla fossa is normal. No deviation of the uvula. Systemic examination, RS bilateral normal vesicular breath sounds heard. No added sounds. CVS S1, S2 heard. No murmur. Per abdomen, soft, non-tender, no organomegaly. Bowel sounds are heard. Here, coming to the summary, here is a 62-year-old male. Came with the complaints of progressively increasing swelling in the left lateral side of the neck with recent onset of pain. On examination, multiple mobile swelling in the left posterior triangle of the neck with smooth surface, hard in consistency. I would like to anatomically lymph node enlargement. Pathologically, it might be a primary lymph node malignancy.
So you're finished with your presentation?
Yes, sir.
One thing probably when you mentioned in the starting, you mentioned started off with a old man.
Yes, sir.
Avoid those terminologies, probably not very well accepted.
Yes.
Not to mention as a old man. Okay,
Yes.
number one. And number two, when you coming to your diagnosis, you have hit upon diagnosis of primary lymph node malignancy.
Yes, sir.
In the history wise, there probably we were okay with tuberculosis. As you said, it's the most common feature.
Yes.
Now, why you went into a lymph node malignancy? That way, a primary lymph node malignancy.
Because there are multiple lymph nodes are present, sir. And also on the history wise, there is no history of weight loss and no history of evening rise of temperature. And on examination, there is no matting of the lymph nodes are present, sir, which usually TB lymphadenitis will present with matting of lymph node. But still we can't rule out because hyperplastic variety can also be there, sir. And there are two other primary and the swelling is hard, sir. And over the summit also, only over the summit, it's tender, sir.
Primary malignancy will you get hard consistency.
And other two are firm, sir.
But
Don't you think
Firm.
probably a little bit?
primary swelling. You said it's hard in consistency, right?
Yes, ma'am.
Why can't it be secondaries in the neck?
At this level, as there are no other primaries, I have examined
Because
oral.
you have seen all the oral cavity, and because
Yes,
of
sir.
that you didn't get any lesion. That's why I'm not telling it is secondary. As Madam told, it might be a secondary. It might be in the esophagus.
It can be, sir, but on examination, we can keep it as secondary or primary, sir. But most
Yeah, but you
likely,
never talked
it's
about
in the,
secondary at all. You have
it's
a
in the
diagnosis of
post-
only primary, right?
You could
it's
have
in the
given a differential
posterior,
diagnosis.
because it's in the posterior triangle, sir. Secondaries are most commonly in the upper cervical group, sir. So I would keep it a diagnosis because it's in the posterior triangle, more commonly primary, sir.
So which level group of lymph nodes are these?
Level 5, sir. Level 5, ma'am.
Okay, level 5, what are the primary draining areas?
Level 5, mostly from the posterior, posterior, and also from the nasopharynx it will drain, ma'am, and from the scalp.
Is it only that much? Then, but you are making a diagnosis of primary. There can be secondary. These are all draining areas, no?
Yes, but we can't rule out. But secondaries are most commonly in the level 2, ma'am.
So level 3, they don't come.
They'll come, ma'am, but most commonly in the level 2, it will be there, ma'am. And it's in the posterior triangle. Mostly it will be a primary, ma'am.
Why you didn't want to enter a differential
Arun, sir.
diagnosis of tuberculous, suppurative tuberculous node here?
Because there is no matting, sir. And
Need-
it's also in the posterior triangle, sir. Tuberculosis also presents mostly in the level 2, sir.
What are the stages of TB lymphadenitis?
First, stage 1, there will be inflammation of the lymph nodes, sir. Lymph node, ma'am. 2, where there will be adenitis will be there. Then there will be matting of the lymph nodes. Then cold abscess, collar stud appearance, ma'am. Then there will be a sinus formation.
So you are saying because there is no matting, I don't want to give a diagnosis of tuberculosis. That's what.
But we can't rule out hyperplastic
I am not telling, madam. You are only telling.
We can keep
it. Only saying it is. It cannot be TB because there is no matching.
And also it can't be TB just because it is in the posterior triangle. That's also not true. Lymph nodes, tuberculous lymphadenopathy can happen even in the posterior triangle.
Yes, sir.
So it not necessarily, it should not.
Yes.
And there is pointing. What is it pointing due
to? That might be due to superficial infection following FNAC, ma'am.
Of a primary lymph node malignancy?
Yes, ma'am. After
what is the
FNAC,
incidence of infection in the lymph nodes malignancy? Primary means something like lymphomas, probably you're thinking of, right? So
Yes,
what is the incidence of infection and presenting as pointing as an abscess?
The incidence is less than 5%, ma'am.
So you're giving a rare diagnosis.
Yes.
And also you're making it more rare by telling that following FNAC, the infection has occurred.
This has occurred.
Might be just the
Why do
skin,
you think?
which might be.
How many times the FNAC has caused infection?
Exactly. So I don't think that is appropriate at all.
Small little it is. 24
post-infection
number.
it is.
Little.
Always you should correlate with the primary diagnosis, not with the procedure.
So you should look at it. There is a pointing abscess. So what is more common? You have to think of an infection, first of all.
Tumor necrosis.
It looks like you are fixed with the diagnosis because you know the diagnosis.
What about the previous scar, madam? What you told from previous scar?
15 days ago, he had a history of some surgery was there for which similar swelling he had. That's what he said, and that was excised, it seems, ma'am, and was sent for that might be for excision biopsy.
Okay. Chetana, you must understand when you present,
Yes.
you should always give a probable provisional diagnosis, keeping all in mind. You cannot dogmatically go and say, yes, this is the diagnosis. So from this, it will be very well understood that you know the diagnosis, and so you are trying to fit everything into the diagnosis. You should always give differential diagnosis, and whatever could be the final report, you should always give what is most common as the first diagnosis. You have to give points in favor and points against for the differential diagnosis. So you are giving different points, isn't it? So when there are different points in favor and some points against, you have to give differential diagnosis. You cannot stick to one diagnosis. Okay, that is the first correction you have to make.
Hard consistency goes against primary malignancy.
The secondary, the inflammation itself can make the lymph node immobile. Any swelling immobile, right? Inflammation is one of the causes for swelling to be fixed.
Yes.
So here we are seeing inflammation. So why not tuberculosis with infection and going in for an abscess?
Yes.
So to reiterate what Dr. Kalaivani was
Now-
telling, I should
now
say
if you have to
probably
go-
in this case, you should have mentioned it as differential diagnosis of tuberculosis and also probably lymph node malignancy. Primary or secondary, that's later.
Yes,
Comes
later.
into the discussion later, number one. And number two, then you discuss what are the points for and what are the points against each of them. And definitely you should have mentioned it as either as a suppurative lymphadenitis, which has opened up and caused a summit, whatever the opening, and then skin breach, what you've been seeing, or probably a tumor necrosis if you're considering malignancy. What you mentioned post-FNAC infection is totally
Not acceptable.
unacceptable. You
Not
should
acceptable.
never mention it ever again. No, not at all acceptable.
Now, can you summarize or can you do 1, 2, 3 differential diagnosis and let us know what investigation you want to do?
Yes, first, I would like to keep a diagnosis of TB lymphadenopathy, sir. Then I would like to keep a diagnosis of lymph node malignancy, either primary or secondary.
Which one first? Secondary first or primary first?
Secondary, ma'am.
Which is most common? Secondary, isn't it?
Secondary,
So
ma'am.
go
Yes,
in
ma'am.
that order only.
Yes, ma'am.
Final diagnosis can come anything, and you know there is also something like secondaries of unknown origin. So you may not be able to find out the primary also. Still, they can be secondary.
Yes, ma'am.
Okay, so always what is most common will be in the front, especially when the diagnosis is not very clear cut.
Yes, ma'am.
Okay, yeah, proceed with the next investigations you were asked.
Yeah.
First,
Chetana, one more thing. There are two questions in the chat box which I would like to put forward. Dr. Rajgopal Shenoy sir is asking, what is the natural cause of lymph node this enlargement in case of TB, lymphoma, and secondaries, which I think the examiners have already put forward, like to you. What is the natural cause? One more question is from Dr. Naz, where she's asking, is matting only a feature of tuberculosis, or it can be get in malignancy also? Please answer that question.
in malignancy also, there can be matting might be present in the later stages.
What stage is that?
Stage 4, ma'am.
It's not stage.
Lympho. In the later stages.
Okay, what is the cause for matting in TB? What is the cause for matting in lymphoma? You tell me now.
In case of matting, in case of TB, it's periodenitis will be there. Because of that, it will cause matting, ma'am.
In malignancies?
In malignancy, there will be subcapsular breach will be there.
Capsular invasion resulting in spread to the surrounding. Okay, fine. Okay, now proceed to the next.
Before we proceed, Dr. Shenoy has put one more question. Shenoy,
Yeah.
sir, he
Can
has
it
put
be a papillary?
why can't this be a lateral aberrant thyroid or a papillary CA thyroid with
Pigments.
metastasis to the node?
Yeah.
Because of the age, 62-year-old.
So?
And it's in the posterior triangle, not in the lateral, sir.
No, Dr. Chetana, that is why I asked you, what is the draining area for posterior triangle? You should have read what are the draining areas of all the group of lymph nodes. So this comes under what level group of lymph nodes?
Level 5.
Level 5. So in level 5, what are the draining area?
Occipital region, then nasopharynx and posterior from the back of the shoulder also it will drain.
Thyroid doesn't drain there?
Thyroid mainly level 2 and 3, ma'am.
So this is not a draining area for thyroid then. Nasopharynx, oropharynx,
Or
thyroid, for all these, posterior triangle is a draining area. You must keep in mind. That is why sir is giving you a hint. Thyroid.
yes,
Okay, they're all draining areas. Okay.
yes.
Okay. What next?
Next, I would like to get a USG of the swelling, ma'am.
For what?
USG of the swelling to look for the consistency, echogenicity, and also to look for the vascularity. Following that, I would like to get USG guided FNAC, ma'am.
When the lymph is swelling is pointing out at you, you want to do ultrasound guided FNAC. So when do you do ultrasound guided FNAC?
Because I don't want to take out the necrotic tissue, ma'am. If I do blindly, if necrotic materials are there, it will not yield.
You don't feel, you said no, the rest of the swelling is hard in consistency.
Yes, ma'am.
You can't take FNAC from that area?
We can take, ma'am, but better to take USG guided, ma'am. So properly, we can see where the necrotic tissues are not there, and we can take the adequate sample.
Now that they have done already FNAC, would you like to go and see the report? Or you want to do, before doing FNAC, they would have done a USG of the part? That would have been a better option.
I would like to get a USG, then
You want to, which one is the first?
USG, sir.
USG of what? Ultrasound of what?
USG of the swelling, sir.
Of the swelling.
You also said to assess the vascularity, you want to do USG. How is that going to make a difference?
If we are going for a blind conventional procedure, if the vascularity is more, if it's my vascularity is more, then we might cause a lot of hemorrhage conventionally.
See, first
This
of
is
all,
a swelling which is already broken up and there is a discharge of necrotic material coming from there, from what we see from the photo. So obviously it is not a very vascular swelling. So as Dr. Kalaivani says, probably in this case, you don't need an ultrasound guided FNAC or whatever. There is no need for an ultrasound scan. You can directly go in and do the FNAC from a hard area, wherever you feel the swelling, away from the necrotic area.
Okay.
Nothing wrong, but then probably your justification is not very appropriate. Doing an ultrasound is not wrong. We won't say it's wrong, but then probably your justification is not very right.
say for example, this FNAC comes out as squamous cell carcinoma. How will you proceed with?
If it comes out as a squamous cell carcinoma, I would like to trace for the primary, ma'am. Where is the primary? For tracing for the primary, I would like to get mostly thyroid. I'll check, ma'am.
This, if you had mentioned in the ultrasound, may have made sense. I want to see if there is any thyroid nodule or anything there, abnormality in the thyroid when I done the ultrasound of the neck, not only the swelling. If you had mentioned ultrasound of the neck to look for other nodes, to look for the thyroid, if there is any other disorder or any nodule in the thyroid, which probably could be the cause, that would be more justified. That's why I said, you asking for an ultrasound may not be wrong, is not wrong. But then how you justify it? Not by the vascularity, not by the hardness and other things, such a obvious swelling. So it's more important is other, away from this, like thyroid and other things. So probably to rule out those things.
Squamous cell carcinoma, FNAC, do you look for thyroid?
Mostly pan endoscopy will do.
No, but you said lymph node, I said secondary is squamous, and you said primary workup first is thyroid.
Pan endoscopy will do, ma'am.
Why pan endoscopy? When is pan endoscopy indicated?
When we not find the primary, ma'am.
When you can't find the primary.
Primary tumor. For the workup, will do, ma'am.
No, it's not like that. When you can't find primary on clinical examination of the oral cavity, then what all you look for in oral cavity? Tell me.
Oral cavity, we'll see if there is any CA buccal mucosa, CA floor of mouth, and also for the if there is any in the tonsillar bed, Then we'll look for if there is any indurations are present, ma'am, over the lateral aspect.
So when we say oral cavity, what are the components of oral cavity that we should look for?
Firstly, we have to see for the floor of the mouth. If there is any
So just tell me the areas to be examined.
Floor of the mouth, buccal mucosa, gingivo-buccal groove, then tonsil and tonsillar bed.
You'll not examine the tongue?
Hard and soft palate, then tongue. Floor of the mouth.
Okay. Now you don't find any primary in these areas. What next?
Next, I would like to do the pan endoscope and look for any primaries are there, ma'am.
What do you mean?
Before you do pan endoscopy, anything else, any other investigation? Because pan endoscopy, you do only an endoscopy, or what else will you do?
Endoscopy, then laryngoscope, bronchoscope is also done, sir.
Okay.
So when you say pan endoscopy, it is what on?
Endoscope.
What endoscope? You said pan endoscopy. So
upper GI endoscope, bronchoscope, then laryngoscope.
Nasopharynx.
No.
Okay, supposing when you do this pan endoscopy, you don't find any obvious lesion. What next?
I would like to go for to check in the hidden areas, sir. Occult primary surveillance biopsy. I would like to take.
Wait, this is exactly what I didn't want you to say right away. You want to do a surveillance biopsy, or was there any other radiological investigation you would like to do before surveillance biopsy? Because surveillance biopsy is an invasive procedure. If you're able to arrive at a diagnosis without any invasive procedure, then why not?
CECT neck, sir.
CECT neck.
Chest.
CECT of the neck.
CECT neck and chest.
Neck and chest. Not abdomen. You can go a little down. You have to be specific, ma. We are talking about if it is secondary of unknown origin. First, you said all the clinical examination. Next in order was pan endoscopy.
Yes.
Now, next, all these are negative. Then next, you said the hidden areas.
Yes.
So, what are the hidden areas?
Hidden areas are for fossa, piriform fossa, then fossa of base of the tongue, then valleculae, fossa of Rosenmuller's, posterior 1/3 of the tongue.
You told already. Tongue you told twice.
If I can tell, hello.
Yeah, please.
If I can tell, the most common areas we look into is the tonsillar crypts.
Yes.
Followed by the fossa of Rosenmuller, the nasopharynx, base of tongue, valleculae, piriform fossa, particularly the apex, and maybe the glottis. Also, even though the lymph nodes from involvement from glottis or subglottis is less likely, subglottis is more likely than the glottis, but still, these are the places where we take random biopsies from.
Yes.
Okay.
Yeah.
And if you don't know the primary, even on pan endoscopy, it's better to do a PET CT scan. It will help you to guide, do a targeted biopsy.
That is what I was trying to hint at telling you. Rather than going into surveillance biopsy, was there any role for a PET CT?
Yes.
So you should go in that order. If facilities are available, then I would like to do a PET CT scan, because if that is going to give you a diagnosis, then we are there. You can do a focused biopsy if required subsequently.
Yes.
Okay. So your understanding, you have to go in that order. It's not randomly. It is this only, so I'll do this only. It's not like that. You have to go in a specific manner, especially if the FNAC comes out as this secondary sex squamous cell carcinoma. So you have to find out all the primaries related to squamous cell carcinoma. Okay. Fine. So these, how do you remember this area of biopsies? So it's just RPTS. Okay. R, fossa of Rosenmuller, just to make it simple for you. Fossa of Rosenmuller, and PP. What is this PP? lateral wall of pharynx and piriform fossa, 2 Ps. And then 2 Ts, the tonsillar bed and the posterior third of the tongue, and a subglottic region. Okay. So RPTS, R double P double TS. It's just to remember. Okay. Simplified. Okay. Sir, next, sir, Arun, sir. Next, what we can.
So what's the FNAC report now that we have finished almost all the investigations? What are the reports which you know of? What's there in this case investigations?
FNAC smear study shows areas of necrosis with atypical lymphoid cells, which are medium to large size, having scant cytoplasm and irregular course nuclear distribution. Impression, they weren't sure if it's a TB lymphadenopathy or if it's a lymphoma. So they said us to go ahead with excision biopsy, sir.
So you did excision biopsy because you were advised by the radiologist or you wanted to do?
No, we wanted to, ma'am.
Exactly. Okay. This is how you will plan. Every time it shouldn't say medicine said this, so I am doing this. Radiologist said this, so I am doing this. It's not like that. It is your way of taking the patient ahead. Getting it, Chetana, you're getting it. Don't tell, they said I'll do. They said I do. So since we didn't get a proper diagnosis in the FNAC, we will proceed with, or I will proceed with excision biopsy. Understand?
Yes.
What is the excision biopsy report?
Madam, we have another 5 minutes for discussion because we have to go on with the next. Yes.
Biopsy
Thank you.
report?
Excision biopsy specimen consists of single gray white mass measuring 2 cross 1.5 cross 1 centimeter. Externally soft to firm in consistency. On cut surface, well circumscribed homogeneous gray white areas are noted. Section studied shows structures of lymph node appearing matted. The architecture is effaced and replaced by necrosis rimmed by epithelioid cell, histiocytes along with lymphocytic infiltration. One of the large lymph nodes shows extensive coagulative necrosis with one of the tiny viable foci showing monotonous appearing discohesive lymphocytic cells with large nucleus with multiple nucleoli. In the necrotic area, cellular outline of the monotonous appearing cells are evident. Capsule also shows infiltration by mixed inflammatory cell infiltrates. Impression, features are suggestive of non-Hodgkin lymphoma with extensive necrosis.
So now we know where your diagnosis comes from after your clinical examination.
Okay,
That should not happen.
That is what, in your presentation, you made it evident that you knew this diagnosis and so you're presenting like that. Okay, so you
One more
should
primary diagnosis was primary lymphoma. Why did you go for FNAC?
Because we weren't sure of if it's a TB.
No, when you are made a diagnosis, you didn't give differential diagnosis also.
Okay, we are just trying to tell these are the things which you are not supposed to, and this is how you should present. Okay.
When you're sure of primary lymphoma, you should go for excision biopsy directly.
So all these arguments will come in the exam. So we're just training you not to make such arguments. Okay. So next. So now that it has come as non-Hodgkin's lymphoma, what you want to do next?
I would like to go ahead with chemotherapy for the patient. I would like to send IHC and.
You should stage the disease, no?
Yes, sir.
You will not stage the disease?
We have to stage the disease.
So what we should do next?
CECT, ma'am. CECT, abdomen, pelvis, and thorax, ma'am.
Why don't you go for PET scan directly?
In our institute, it's not available, so we didn't go ahead with that.
No, you should answer what is done, not in your institute.
If it's, we can go ahead with PET CTs.
Now that you don't want to go with the USG abdomen, only it's done that you are done, make a neck diagnosis and that's final, and you want to start treating and you don't want to see any other case.
We need to see if there is any splenomegaly or hepatomegaly, sir.
So for that, what you have done. And one more thing, you are telling cross. Please tell it's into.
Yes, sir.
Yeah. So what was the question of finally? Hello.
Madam, they have made a diagnosis of neck swelling Do you know that they don't want to do any ultrasound abdomen and see other lesions in the abdomen?
I would like to go ahead with USG, abdomen and pelvis.
He wants to do CT straight away.
To look if there is an
why not ultrasound? Why CT? Abdomen?
First, we can go ahead with USG, ma'am. After that...
No, you answer to my question. Why not CT? When why ultrasound? And why not CT? CT is better or ultrasound is better in this case?
CT, ma'am.
Why?
USG, it can be a subjective finding as well, ma'am.
CT what are we looking at now? What are we looking at?
We can also find if there are any lymph nodes in the para.
We are looking at lymph nodes, not that we can find lymph nodes. Please understand that. We are looking at lymph nodes. We want to look at the lymph nodes in the abdomen.
Abdominal.
So CT is the one which will pick up lymph nodes better than an ultrasound. So this is the indication here. That is why all cross questions are coming, because you are missing on a lot of things. So CT scan, CT of the thorax and the abdomen. Yes. So what will you look for in thorax and abdomen CT?
In the thorax, if there are any mediastinal lymph nodes, and in the abdomen, I would like to look for para-aortic lymph node, and if there is any splenomegaly, hepatomegaly is there, and also inguinal lymph nodes also if it's there, axillary lymph nodes.
Splenomegaly and hepatomegaly more common in primary Hodgkin's, not non-Hodgkin's.
Yes, yes.
What are the common GI non-Hodgkin's lymphoma sites? Should look that.
Can there be primary GI lymphomas?
Yes, ma'am.
What are they
What
called?
are the common sites of abdominal non-Hodgkin's lymphoma?
Malt.
No, you should read.
Okay. Okay, fine. You need to read a little. These are called as non-lymphoid areas. Okay.
Yes.
Fine. What else? So now you proceeded with what are the findings? Please tell the findings of chest CT and abdomen CT.
Few enlarged lymph nodes.
Read the CT film, no? Read the CT film.
Yes, sir. Here you can we can see a lesion of size approximately 6.3 cross 3.4 centimeter on the left side of the cervical region, mostly really in the level 5.
No, time is short. You just tell this abdomen and chest findings, sir.
Abdomen and chest, there were no lymph node. Only cervical lymphadenopathy was there, sir.
What is the stage of the disease?
Stage 2, sir.
Stage 2. So there are no lymph nodes in the abdomen, you said, right?
No, ma'am.
No lymph nodes.
No, ma'am.
So only cervical group of lymph nodes.
Yes,
A or B?
Stage 2.
Only cervical stage 1, no?
There were a few multiple lymph nodes.
Find out, Chetana. We have to find up. We are time up.
Yeah, because we don't have time for the next.
You
So
need
I
to
think
find up.
with
So
the
you tell
permission
me
of the
what is the
examiners.
correct stage now as for this and what treatment in one line you tell.
Stage 2, and I would like to go ahead with chemotherapy.
Why stage 2 you have to tell?
Because it's above the diaphragm and multiple cervical lymph nodes are involved, ma'am.
2 groups of lymph nodes are involved?
Cervical, both on CT, there is on the right side also it's present, ma'am. Lymph node present.
Fine. Okay. So treatment?
No.
Sir, anything, sir?
2 group means neck and mediastinum, not neck. Whole neck is stage 1.
Okay.
2 groups, if it is involved. Sir, Arun, sir?
Yeah, nothing from my side. I think probably we have to wind up and go on to the next case.
So stage 2 means it is 2 or more involved lymph node regions. Okay, different regions.
Yeah, Dr.
Fine.
Shilpa,
So-
can I request you
Yes,
to
yes,
just give a
Yes,
quick
sir.
summary of
Yeah.
this so that we can move to the second, please? And some questions
Chetana,
are
you
there,
please.
we can also take.
Yeah.
Yeah, please.
Yeah, please unshare your slides, and then there are some this question from Anish. What would you examine the testis in this patient, because he's got this history of lymphoma? Would you examine the testis? You have not mentioned anything about the testis examination.
Male
Chetana.
patient,
Male patient.
testis external genitalia examination is a routine. It is a part of the examination in the male patients. Because the male patients drainage of the testis in the para-aortic group of lymph nodes, so it is a part. But in female patients, please on inspection, don't say external genitalia normal. Okay? The concerned organs are intra-abdominal in female. So in the male patient, you have to examine the external genitalia and it has to be mentioned. Okay? Anything else, Shilpa?
Yes. Most of the other questions have been answered, madam, and there are few suggestions made by a few of the surgeons.
Yeah.
Other than that, the questions are not there. They are just suggestions. Marginal cell lymphomas or indolent H. pylori treatment may be curative, as suggested by Dr. Venkatachala.
As that could be one of the etiologies. Even she didn't mention that alcohol intake and smoking, they're also risk factors, not only for lymphomas, also for all the next secondaries and primaries. They're all important risk factors which you should have taken into consideration. And Chetana, what you have to read is the anatomy of the neck, the lymph node, the levels of lymph nodes, what are the levels, when do you, on what basis you describe as level 1 to 6, and what are the draining areas you have to read. Okay, and differential diagnosis you should always give. Then you give points in favor or against. Justify, or whatever is not favor, tell this point is not in favor. Okay, so don't stick on to one diagnosis, especially when it's not very, very clear.
And most
For
of
thyroid,
them
you don't have to give thyroid or lymph node as differential diagnosis. Thyroid is thyroid only. Okay, but here.
And when only neck is involved, it is always stage 1, as suggested by others also.
Yeah.
Now, never say infection following FNST.
Yes. Okay, these are the few corrections for you, right? You have to read little more in detail.
Yes. Ma'am, can we go on with the next presentation?
Yes.
Yes, now I welcome Dr. Akhil Gupta to come.
Congratulations,
and start his
Chetana, take care.
presentation. Yeah, to start his presentation, and kindly share your slides, please. Dr. Akhil. Share your slides, Akhil.
Yes, ma'am.
Yeah, please proceed. Make it to a full screen and proceed, Akhil.
Yes, ma'am.
Slide share, yeah.
Yes, ma'am.
Yeah.
Going to all the dignitaries. This is Akhil, postgraduate student from the Department of General Surgery, KMCRI Hubballi. And today I'm here to present a case presentation on mass per abdomen under the mentorship of Dr. Shilpa Huchanevar ma'am, Professor and Unit Chief, Department of General Surgery, KMCRI Hubballi, and our beloved HOD sir, Gurshanta Pelagachin sir, Principal and HOD, Department of General Surgery. Coming to the case, here is a 50-year-old gentleman hailing from Koppal, Karnataka, farmer by occupation, came with the chief complaints of abdominal pain and distension from last 15 days. Patient was apparently asymptomatic 15 days ago, after which he developed pain in the upper abdomen, which was insidious in onset, continuous in nature, dull aching, moderate in intensity, and non-radiating, more in the right upper abdomen, no aggravating factors, relieved on taking medication, for which he was consulted. He had consulted the local physician, following which he was referred to KMCRI Hubballi. Patient also complains of abdominal distension from 15 days, which was insidious in onset and gradually progressed. Patient also gives a history of loss of weight, that is 7 kgs in last 3 months, and loss of appetite. There is no history of any nausea or vomiting, no history of fever, no history of any previous recurrent attacks of abdominal pain, no history of any yellowish discoloration of the eyes and skin and itching, no history of altered bowel habits, no history of any early satiety, hematemesis, or any blood in the stools, No history of any previous blood transfusions in the past or drug abuse or any previous surgical interventions. No history of any breathlessness or cough. No history of any bilateral lower limb swellings. Patient is in a newly detected case of type 2 diabetes mellitus, not on any medication. Patient had history of cataract surgery for the right eye 8 months ago. History of right-sided hemiparesis 3 months ago. Took Ayurvedic medication. Not a known case of hypertension, bronchial asthma, cardiac illness, and tuberculosis.
There
is no history of similar complaints in the family. No history of any cancers or cancer-related deaths in the family. Coming to the personal history, patient consumes a mixed diet. Sleep is adequate and undisturbed. Bowel and bladder habits are regular. Patient is a non-alcoholic and non-smoker and chronic tobacco chewer for the 15 years and left the habit 8 years ago. Coming to the summary of my history, here is a 52-year-old newly detected diabetic male came with the complaints of dull aching pain in the right upper abdomen and abdominal distension from 15 days with a history of significant loss of weight and loss of appetite.
Dr. Kalaivani, your turn.
Yes, sir. So what do you think at this stage? What are you dealing with? How we want to proceed?
At the end of my history, I'm thinking it can be any chronic liver disease, or if I take into consideration the significant loss of weight, I can think of malignancy because the age of the patient is also elderly patient.
52 is not elderly. You were just corrected. You have to go through the recent WHO classification. Okay, all these comes under middle age. Anyway, at the end of history, you have to tell which are the anatomical organs that could be involved.
Yes, ma'am. Most probably, the patient is complaining of right upper abdominal pain. So it can be primarily from the it can be from the liver, it can be from the hepatic flexure of the colon, it can be from the pylorus of the stomach, it can be even from the omentum.
Why not gallbladder?
It can be from the gallbladder. It can
Again,
be from the
again, all of you are getting stuck with the diagnosis.
It can be from the gallbladder.
Yeah, I'm very specifically my question I'm asking. What are the anatomical organs?
It can be from the gallbladder.
Yes. First thing is liver, then the gallbladder, then the entire biliary tree there, and
Yes,
then go to the other organs.
Yes, ma'am.
Okay. The immediate vicinity for the right upper abdomen, right?
Yes, ma'am.
Okay. Sir, Arun sir, anything else?
Yeah. So probably as it says, now which organ do you think is involved in this case?
Sir, as patient is complaining of abdominal distension and patient is having right upper abdominal pain, it can be most commonly maybe liver.
Sorry, what about your habits? What is about his habits? What did you mention about that?
Sir. Sir, patient is non-alcoholic and non-smoker, but a chronic tobacco chewer 15 years. He had the habit 15 years and left the habit 8 years ago, sir.
Fine. So you probably feel that the organ involved is the liver.
Yes.
Okay. Proceed.
Yes. So coming to my examination, patient is examined with informed consent in a well-lit room with adequate exposure from the nipples to mid-thigh in supine position. Patient is moderately built and moderately nourished with a BMI of 21.1 with the ECOG score of 1. Patient is conscious, cooperative, well-oriented to time, place, and person with pallor, clubbing. There is no evidence of any icterus, cyanosis, lymphadenopathy, or any pedal edema. Skin, pubic hair, axillary hair are normal. No muscle wasting. Vitals, patient is afebrile with a blood pressure of 130/90 millimeters of mercury, checked in right arm in supine position, with a pulse rate of 84 beats per minute, checked in right radial artery. Pulse is regular in rhythm, normal in volume and character, with respiratory rate of 20 cycles per minute and maintaining saturation 98 at room air. Coming to the examination of abdomen, on inspection, abdomen is uniformly distended. Both the flanks appear to be full. Umbilicus is central, inverted. There is no evidence of any nodules. Corresponding quadrants move equally with the respiration. No visible scars and dilated veins. No visible peristalsis. External genitalia are normal. Hernial orifices are intact. Coming to the palpation, abdomen is soft, non-tender. A mass is palpable in the right hypochondrium, extending 10 centimeters below the right subcostal margin in the mid-clavicular line. Mass is having irregular and lobulated surface, hard in consistency throughout, and moves with respiration and is non-tender. Lower border is sharp and fingers couldn't be insinuated below the right subcostal margin. There is no splenomegaly, no supraclavicular lymphadenopathy, no renal angle tenderness or fullness. Hernial orifices are intact and external genitalia are normal. On percussion, liver dullness is noted from the right sixth intercostal space, and the dullness is continuous with the mass in the right hypochondrium, about 8 centimeters below the costal margin along the mid-clavicular lane. Liver span is 21 centimeters, and shifting dullness is present. On auscultation, no bruit heard over the mass. Bowel sounds are heard. Parectal examination, mucosa is normal. Sphincter tone is adequate. No evidence of any nodularities or deposits. Yellow staining of the examining finger noted. No melena, no prostatomegaly. Other systems examination, respiratory system, normal vesicular breath sounds heard, no added sounds. Cardiovascular system, S1, S2 heard, no evidence of murmurs. Central nervous system, no focal neurological deficits present. Spine and skull examination is normal. Coming to my summary, here is a 52-year-old recently diagnosed diabetic male who was a chronic tobacco chewer, presented with the complaints of right-sided upper abdominal pain and abdominal distension since 15 days with loss of appetite and significant loss of weight. On examination, mass of size 10 × 6 centimeters, palpable in the right hypochondrium with irregular and lobular surface, hard in consistency with moderate ascites. My clinical diagnosis, anatomically, it is a probably hepatic mass. Pathological can be primary in the liver or any secondaries in the liver.
So is the surface nodular is what Dr. Venkatachala
Yes, there's a correction from Dr. Venkatachala. It is not nodular, it's not lobulated, it's nodular. There's a correction.
Ma'am, but the size of the nodule is like about more than 3 centimeters, which I could palpate, ma'am. That's why I had put it as lobular.
In between the nodules, it was 3 centimeter.
Yes, ma'am.
Sir, Arun, sir?
Yeah, first and the foremost, you said in your findings, if you go, you said abdomen is uniformly distended.
Yes, sir.
I don't think abdomen distension is there or no distension. That's why there is nothing like uniform or localized distension you don't get.
Okay, sir.
So that's one thing. Because when you're telling all these things do matter because it leads to unnecessary questioning from the examiners. When do you think it's uniform distension and when there is a localized distension?
Yes.
Okay, fullness is different when you see in inspection. We see fullness in the right hypochondrium or in the flank area. That is different. But when you're talking about distension, just say abdomen is distended, number one.
Yes. Okay.
And number two, you said it's a nodular surface of the liver, which is formed to hard and dull.
Yes, sir.
And in your clinical diagnosis, you have come to a final diagnosis of a primary HCC as your first diagnosis with secondary as a possibility.
Yes, sir.
Is it right, or do you think it should be in the other way around, reverse?
Sir, considering like most common is secondaries in the liver, sir, than primary HCC.
Then?
So like first diagnosis in the provision, it can be secondaries in the liver. Next I can take HCCs.
Yeah, but in your thing, you mentioned the primary HCC.
Yes, sir.
And with the nodular surface and all the other findings. Okay, well, now tell me, what are the characteristic features of a secondaries in the liver? If you're
Sir, secondaries in the liver, first thing, it can be multiple, sir.
Multiple what?
That is why it is nodular. See, when you say nodular, that is what it's multiple. Secondaries are multiple. So
Yes.
it's when you say it is nodular, we have to first think of secondaries. And
yes.
don't say it can be. It is.
Yes.
Actually, that's what I'm trying to say. The first diagnosis should have been secondaries in the liver.
As a first diagnosis. Okay.
Yes.
Yes.
But on examination, most of the secondaries in the liver will have umbilication over the nodules, but which I couldn't feel in this. So I had put.
Is it mandatory to have umbilication?
80% 80% of the secondaries will present with umbilication.
Now, when do you get that umbilication?
When there are when there is central necrosis.
Yeah, okay. But it is not necessary that umbilication is a mandatory for you to say that it is a secondary.
Yes, sir.
Okay, primary. Now, what are the primary features of the primary HCC clinically?
Clinically,
your findings. In any case of a primary HCC, what could be the findings?
In case of a primary HCC, I could if I have to take there clinically different types of HCC are there, sir. There is a nodular variant of HCC also, so I could take it as it also as a differential diagnosis, sir. That's why I had put it in the first nodular kind of HCCs.
See, what is more common?
Secondaries, ma'am.
Secondaries. What is more common? You have to give at first diagnosis.
Yes.
Okay. You give rare diagnosis, passing also will become rare.
Yes.
Okay. So always give what is common, you give first. Your previous candidate also did the same thing. You are looking at the final diagnosis and your discussion is going in that direction, which is not right. You have to always forget about what was the final discussion based on your history and examination and what is most common.
Yes.
That should be your
secondaries
first
is the most common.
diagnosis. Yes. You have to give
And the
that.
foremost application, need not be mandatory for you to say it is a
Yes.
secondary. And also more importantly, you may not be able always to appreciate the application.
Yeah.
You may
Very
miss it.
rare again.
Okay.
Not that, it will be
Maybe
waiting
there.
for you to feel it. So, miss it. So when such is the case and knowing very well, like how you're mentioning in the neck swelling, the
Yes.
most common neck swellings are lymph nodes. Likewise, in a liver lesion like this, where there is all indications towards it to be something, a malignant lesion,
Yes,
and findings wise you feel that it is a nodular surface and other things, then probably it is better to give secondaries as the first diagnosis.
Sure. Yes.
Okay.
Yes.
Fine. So this is, you have to correct it. Let
Yes.
the final diagnosis be anything, but you have to put what is in that order of frequency. Fine.
Yes.
Now, how will you go ahead with the next? Something I wanted to ask, I forgot. Okay, when I remember, I'll tell you.
Yes.
Next.
First thing I want to confirm my diagnosis, ma'am. For that, first I want to get USG abdomen pelvis.
So for a ultrasound,
Okay.
you will confirm the diagnosis?
No, ma'am. Like for the organ of.
Ultrasound
Okay.
you will do just to know the organ of origin.
Yes, ma'am. First,
Okay.
I want to get the USG ultrasonography of abdomen pelvis.
Just a minute.
Yes.
See, before going to the investigations, now you are said your first diagnosis is secondaries in the liver, right?
Yes, sir.
So which are your common primaries which you suspect? Then you go. Accordingly, you target your investigation.
Most common secondaries in the liver is due to colorectal carcinoma, sir. Second is gastric, followed by neuroendocrine tumors, followed by melanomas.
Followed by?
Melanomas, sir. Melanomas are the rarest.
Melanoma. Okay. What about the other organs? Lung?
Lung is very rare, sir.
Okay. Pancreas?
Yes, sir. Pancreas is also. Yes.
Yeah. Melanoma with the secondaries in the liver. Yeah, you can mention it, but then, yeah.
But again, what is common you put first.
Yes.
As you said, GI malignancies are most common. Mainly
Yes.
the colorectal, then stomach, and then you put the less common in that order.
Yes.
When you talk, mentioning also, always put what is most common on top.
Yes.
Okay.
Yes.
Fine. So now from ultrasound, what is that you can get to know?
First, from ultrasound, I want to see like what is the organ of the
Mass is
origin.
from liver or not?
Whether it is from liver or not. If it is from liver, if there are any other lesions in the liver, I want to see the gallbladder status. I want to see intrahepatic biliary radicals. I want to see whether there is any other organ enlargement in the abdomen. I want to see whether there is any.
Which other organ enlargement? You will see bowel enlargement?
No, ma'am. Splenomegaly, ma'am.
You have to be very specific.
Okay.
And many a times in abdomen, you write no organomegaly. You don't look for all the organs enlargement in the abdomen.
Yes.
Liver and spleen is they are systemic organs, so you look for their enlargement. They get involved in all other diseases. So you look for them. You don't look for all organomegaly. So make it very clear. Abdomen, no hepatomegaly, no splenomegaly.
No splenomegaly. Yes.
Okay. Don't say organomegaly. You don't look
Yes.
for bowel. And even in ultrasound, now, what you want to look? The liver. And in the liver, whether it's enlarged, not enlarged, anyway, it's clinically it's enlarged.
Yes.
Whether nodules are there or not. So secondaries and primaries itself, you'll be able to come to a conclusion.
Yes.
Right. What next?
Yes, ma'am.
You have the report? You have ultrasound report?
Yes, ma'am. Yes, ma'am. Ultrasonography, abdomen and pelvis, liver. The liver is moderately enlarged in the size of 18.63 centimeters, shape and echo texture. Hepatic veins and intrahepatic portal vein radicals are normal in size and distribution. Multiple fairly defined hypoechoic lesions are noted in the right and left lobe of the liver. Largest one measuring 3.3 into 2.6 centimeters and shows minimal internal vascularity. Gallbladder is minimally distended, shows irregular wall thickening with maximum wall thickness measures 7.8 mm and shows echogenic sludge with minimal pericholecystic fat stranding. CBD, common bile duct appears normal.
All other normal, right?
Yes, ma'am.
The rest of it is normal. No other findings. Free fluid?
Free fluid, moderate ascites, ma'am.
You also said moderate ascites on clinical examination.
Yes, ma'am, because I couldn't.
Tell that. Ascites, shifting dullness present or not?
Shifting dullness, yes, ma'am. I told shifting dullness.
That's all. Okay.
Yes, ma'am.
Don't tell moderate. Then again, next question will be, when do you call it moderate? When will you call mild? All these questions will arise. You should not put yourself into difficult situations.
Yes, ma'am.
Okay.
Now, this patient, he doesn't have jaundice, right?
No, sir, no jaundice.
Okay, what do you think? What else could be the possibility of the lesion in the liver with these findings and without jaundice?
Like this is going in favor of metastatic, right?
Metastatics, yes.
Again, ultrasound goes in favor of metastatic.
Metastasis.
Before the ultrasound, before you got the ultrasound report, could you think of any other possibility?
In the liver, sir?
Yeah. Could it be a case of macronodular cirrhosis?
Yes, sir. Yes, sir. But the patient is having like significant weight loss.
Loss of systemic symptoms going in favor of malignancy.
Malignancy. Yes.
Cirrhosis, anything else is there in points in favor, in history or in?
No, ma'am. Remaining all examination is normal, ma'am, because patient is having hepatomegaly. It is only initial stage of cirrhosis. I'm concerned.
The patient was consuming alcohol. Was that
no, ma'am,
non-alcoholic history?
Non-alcoholic.
So is that an important history if he was consuming alcohol?
Yes, ma'am. If he was consuming alcoholic, it can be alcoholic liver disease with alcoholic liver cirrhosis.
Cirrhosis.
Macronodular cirrhosis.
You have to argue on that basis. Okay.
Yes, ma'am.
Fine.
Akhil, there's one question in the chat group by Dr. Harsha GV. Without any bowel symptoms, why can't it be a primary HCC?
Primary HCC.
HCC.
Primary hepatocellular. Okay. Since the patient doesn't have any other symptoms, why not hepatocellular carcinoma is the question, right?
Yes, ma'am.
But patient can have like this any paraneoplastic syndrome be like.
No. Again, for you at this stage, if an examiner asks you a question, again, same thing. More common is secondaries. Yes. And they need not have all the symptoms of primary. Many a times they can have secondaries in the liver without any obvious symptoms, which has to be evaluated. Yes. Again, since it is more common, I'm considering that as first diagnosis. Yes. However, hepatocellular carcinoma could be my second diagnosis. This is how you will go about arguing. Okay.
Yes.
I'm giving your answer actually. Okay. Next.
Go ahead.
Yes. Next, I want to get the routine blood investigations. Yes, ma'am. I want to get the routine blood investigations as it is related to the liver. I want to get the liver profile done, ma'am. And patient is having pallor, so I want to get the complete blood count. And I want to rule out any pancreatic or anything. So I want to get serum amylase lipase. And to rule out any history of hepatitis, any presence of hepatitis, I want to get serum HIV and HbSAg profile, ma'am.
Okay, here Rajgopal sir's question is there. If you think it is hepatocellular carcinoma, can you explain the nodularity?
Yes, ma'am. Nodular variety of hepatocellular carcinoma is there, ma'am. There is an entity.
When does it occur?
What do you mean by this nodular variety? We are clinical examination now, okay? Don't try to bring that aspect. When you palpate a nodular liver, first diagnosis has been already made clear. It is secondary.
Yes.
If you definitely offer a diagnosis hepatoma, can be your definite DD, but question is, when do you expect this multiple nodularity? Simple. Can it be a multifocal variety? Can it be intrahepatic spread? That is also explained. Okay. This is in addition to one more comment is also there that nodular cirrhosis, macronodular node. So DD for a both lobes enlargement, the nodular surface clinical examination. DD for a unilobar enlargement of a nodule in the liver. Okay, madam, please take over. Yes.
Okay, you got the point?
Yes,
so still your first diagnosis is secondary.
In the liver.
Yes. So if the examiner asks, Why can't it be primary? Can you explain nodularity in primary? Then all these answers will come.
Yes.
Catch the point correctly.
Yes,
Then
yes.
only you will give these explanations.
Yes.
Don't tell it in the first place. But
Yes.
you need to know. As a PG, you have to know.
Yes.
Okay. Yes. Next, investigation. So all the enzymes are altered in this. Bilirubin is only slightly raised.
Yes, ma'am.
Alkaline
Enzymes are-
phosphatase is on the high.
Yes, ma'am.
Okay. Next, any tumor marker you want to do in now that you're talking about blood investigation? Any tumor marker will rule out primary and secondary?
Yes, ma'am. We can get the alpha fetoprotein level, ma'am. Serum alpha fetoprotein level. If it is primary, it will be raised, ma'am. If it is secondary, alpha fetoprotein will be normal, ma'am.
Other markers?
Been done? Has it been done?
Yes, ma'am. It has been done.
Normal?
It is in the normal range.
Okay.
What about other tumor markers?
Tumor markers.
We can get CA 19-9 and we
Rule
can
out
get
what? CA 19-9 to rule out what?
to rule out any pancreatic or any hepatobiliary carcinomas.
See, when we discussed, you said secondaries in the liver, the most common primary is from colorectal.
Yes.
So what is the tumor marker for a colorectal carcinoma?
Carcinoembryonic antigen, CEA, sir.
Then why aren't you mentioning that? Pancreas comes lower down in the order, right? You mentioned alpha fetoprotein.
Yes.
You mentioned CA 19-9.
Yes.
But I think CEA should come first.
Yes.
Isn't it? You're talking about secondaries in the liver. Then what is the tumor marker? First thing you should mention is CEA. Have you done that?
Yes, sir. We have done it.
Okay. Now, what are the values of these CEA, CA 19-9, and alpha fetoprotein?
Sir, CA 19-9 is more than 1000, sir. CEA is 158.8. Alpha fetoprotein is 8 nanogram per milliliter.
So alpha
what are the normal values of this?
Sir, CEA should be less than 37, sir.
Okay.
CA 99 less than 60. Alpha fetoprotein less than 10.
CEA is less than 4.3 in non-smokers. Not
Yes,
30.
CA 19, CA 99 is less than 37.
19-9.
Yes, sir. CA 99 is less than 37, sir.
Go slow, man. Sir is talking. You're also talking.
Sorry.
Tell now once again.
Without establishing the primary diagnosis, we do tumor markers.
Okay. Next.
Yes.
Shrikant sir is asked something.
Sir, it was not done initially, sir. After getting the diagnosis to rule out, because there is a problem in initial reporting.
What was my question? Straightforward.
Yes, sir.
What if it is a non-malignant condition?
Yes,
You're wasting your time with tumor markers.
Yes.
We want to get one first to confirm that I want to get one CECT, sir. Contrast and CECT.
First, after ultrasound, you should have gone to CECT.
Yes.
Yes.
We got in the same order, ma'am, but you asked and I
fine. Okay, everybody went off.
I think we asked him about the tumor markers.
Yes. Because he was talking about blood, we also got drawn into.
If I can interfere 1 second, madam.
Yeah, please.
Yes. More than 1000 CN99, I will not stop at it. I would ask them to do serial dilution to detect the exact value. Because that will help in assessing response to treatment.
Yes, sir.
Raised CA99 and CEA most likely to be from the stomach. Stomach, sometimes there will be a raised CA99 with raised CEA also. But it can be a hepatobiliary problem also. Biliary problem. Okay.
Yes. Next.
CT.
Yes, ma'am. Next, I want to get one CCT abdomen and pelvis, ma'am.
No, before you put the findings, wait. CT, we got to see CT, abdomen and pelvis, fine.
Yes.
What kind of a CT?
A triple phase CT, sir.
What's triple phase CT and why that is specifically mentioned?
Triple phase CT is we want to get arterial phase, venous phase, and portal vein phase, sir. It is to differentiate between the whether it is.
Wait, come again. Arterial phase,
venous phase, and arterial, portovenous phase, and washout phase, sir.
Yeah, delayed phase.
Delayed phase
or washout phase. So arterial, portal venous, and delayed phase. What do you see in this?
Sir, if it is primary HCC, there will be early arterial enhancement and washout, sir. Early washout.
Early enhancement, and then in the portal venous phase, there will be a washout. Which will be almost a continuing in process in the delayed phase also.
Yes, sir.
Then, if it is that is in primary HCC, what you say?
Primary HCC, sir.
Okay, if it is in secondaries, what are the findings?
If it is in secondary, there will be continuous. It will be continuously hypointense, sir.
Okay.
Yes, sir.
Hypointense lesions.
Yes.
Fine.
Okay. Tell the findings.
Now we go for the CT findings.
Yes, sir. CCT abdomen pelvis, liver enlarged and show multiple well-defined mass lesions heterogeneously intensely enhancing in the arterial phase and wash out in the venous and delayed phase of varying sizes are seen in the liver, the largest measuring 5.2 into 4.5 centimeter in the segment 6 of the liver. The gallbladder is ill-defined, deformed with loss of normal CT morphology with areas of heterogeneously enhancing solid components along the posterior wall and the fundal region, and a wall could not be clearly made out between the pericholecystic fat stranding and lesion seen extending into the underlying liver margins and liver parenchyma, and the lesion is seen to extend into the proximal CBD, maintaining the fat planes with the duodenum hepatic flexure of the colon. The mesocolon and peritoneum thickening and fat stranding noted inferior to the gallbladder and gallbladder fossa. There is hepatization of the gallbladder is seen. Enlarged heterogeneously enhancing lymph nodes seen in the periportal and precaval region. Largest measuring 2 into 1.4 centimeter with moderate ascites. They are the CT finding.
So you should not put CT findings like this. Nobody can read this. One or two films which shows these features, you
Yes,
should
ma'am.
highlight and explain them.
Yes, ma'am.
And that will be useful. Yeah, we
Yes,
can
ma'am.
explain this. Explain one of them.
Yes, ma'am.
With the gallbladder, no, you explain that picture. Gallbladder has been explained, right?
Yes, ma'am.
Explain
But,
that.
ma'am, in this, there is no clear evidence of gallbladder, ma'am, because there is no clear-cut separation between the gallbladder and liver parenchyma, ma'am. There is hepatization of the gallbladder, and you can see multiple lesions noted in the liver parenchyma, ma'am. And there is an infarct in the spleen.
And is this contrast?
Yes, ma'am. This is contrast.
What contrast? What contrast has been given?
This is sorry, ma'am, I didn't get your question. Which contrast, ma'am?
Yeah, whether it is oral contrast or IV contrast, you have to tell.
With both with oral and IV they had.
So you have to explain. CACT with showing these, and in this phase you have to explain.
Yes, ma'am.
Okay. Yes. Explain.
There are multiple hypointense lesions noted in the liver, ma'am. With gallbladder, there is no clear-cut evidence of gallbladder separately differentiated, ma'am. And there are like demarcated well play, like
can't see only in the gallbladder. Sir Arun sir, you can see anything better?
No, can't make out the gallbladder.
I can't see anything.
Can't really make out.
Venkatachala, you want to give some your expert comments on this?
Gallbladder lesions are usually isodense.
Yes.
If you see some thickening in the, maybe in a complementary MR would have helped this case.
Yes.
But generally they are isodense. But if you see a mass lesion in the area of the gallbladder,
yes, sir,
you should have think that there is a disease there.
Yes, sir.
So
you can see something there in the gallbladder area there.
Yes, sir.
In the coronal sections at least.
Where are the lymph nodes?
Only in the precaval regions.
So this is why I said one or two pictures you should have taken a close up, and
Yes.
that would have helped in explaining and for you to understand.
Yes.
Okay.
Which is the portocaval node?
What you should do, Akhil?
Yes,
you
ma'am.
have to go to the radiology department, sit
Yes.
with the radiology consultants. You have to explain and try to understand every anatomical organ and its correlation. As
Yes.
a PT, you have to do that.
Yes, ma'am.
Okay, that's how you learn, even to read a CT film. Okay, please do that.
Yes, ma'am.
Okay, anything next?
We have another 5 to 6 minutes.
Yeah.
What's the final impression in the CT?
Sir, it is a carcinoma gallbladder with.
Where is the CT report? Can you share that, please?
Yes.
No.
The report.
Report.
This is the final report.
Final.
This is the impression they had given.
This is the impression.
Sir, this is not impression. This
That's
is
not
a
impression,
report.
man. That's a finding.
Impression means they will wait.
This is description.
So
Yes,
in
sir.
your clinical diagnosis, you were not talking about gallbladder only, no, Akhil?
Yes, ma'am.
You were go more onto the liver.
Yes.
Okay, that's so you should always a diagnosis, whether UG, PG, consultant, anybody, first the anatomical organs in that region. Then think about what pathology. Then based on the associated symptoms, if the patient had vomiting, you would have thought about obstruction in the stomach or in the duodenum. Cause for obstruction in stomach, intra or extra.
Extra.
Right. If there is no vomiting, no lower GI symptoms, then rule out that.
Yes.
So like that, you should keep ruling out based on the history.
Yes.
Keeping the anatomical organs, ruling out the causes for other primaries, you should give a first diagnosis, second and third.
Yes.
Understand?
Yes.
Okay. So don't miss on history.
Yes.
Now, with this CT findings, now what's your final diagnosis?
It's carcinoma gallbladder with the secondaries in the liver.
Secondaries in the liver. How do you want to confirm the diagnosis?
Sir, as already patient is having ascites and patient is having multiple metastasis in the liver, so it is more like it is an unresectable tumor. So I can go ahead with the FNAC of the lesions in the liver and if needed in the gallbladder also.
You didn't have to tell all these things, man. Sir's one straightforward question. How will you confirm this? CT guided FNAC.
Yes.
That's all.
Yeah, unresectable is different. Inoperable is different. Unresectable is you may not be able to resect, but somebody else may resect.
Exactly.
Inoperable means it is a metastatic
Not
disease,
curable.
advanced disease. It is not operable.
Yes. Okay.
Cannot give a cure.
Yes.
Okay, so here CT guided FNAC. Has it been done?
Ultrasound guided FNAC of the liver lesion is being done, ma'am.
So what's the report?
Which is a suggestive of adenocarcinoma deposits.
So going again in favor of gallbladder only.
Yes, ma'am. Secondaries in the liver.
Secondaries in the liver.
With primary as
probably primary in the gallbladder.
Yes.
This is where immunohistochemistry may be useful to show that CA19-9 marker in the tumor cells in the liver.
Yes.
Okay, right.
Okay.
Yes.
Most of the questions.
Better or look at biopsy better in this case?
Sir, we can, as liver parameters are normal, sir, we can go ahead with the true cut biopsy also.
But if FNAC is
No, the chemotherapy for colon origin, stomach origin, pancreas origin, etc., and hepatobiliary pancreatic, they are different. So it's always better to have a immunohistochemistry.
Yes, sir. So
to know the cell lineage.
Okay. So Akhil, actually your presentation was good.
Yes.
Okay. Little more in detail, concentrate on the history and going into the depth of all these organs. You have to learn about liver, everything about the pathophysiology of the liver enzymes and everything you have to know in detail. The segments of liver you have to know.
Yes.
Okay. Yes. And you have to know the exact anatomy of all these organs.
Yes.
Very clearly. Okay. Then now that the diagnosis is known, so further immunohistochemistry you have to know in detail. And after that, if the chemotherapy is indicated, then what kind it is indicated, and resectable, non-resectable, when, what.
Yes.
All these things you have to know as a postgraduate.
Yes.
Okay.
Yes.
Dr. Venkatachala, any further inputs from your side in this case?
Is the management?
Yeah, management part. Any further inputs?
Sir, as this is like inoperable case, because there are multiple secondaries in the liver involving both the lobes of the liver, and there is already ascites for the patient, it becomes inoperable, sir. So I want to go ahead with the chemotherapy for the patient, sir.
Okay.
Neoadjuvant chemotherapy with the gemcitabine with
no neoadjuvant, man. Where is the neoadjuvant? Where is the
what is neoadjuvant chemotherapy?
Before surgery, without any surgery.
You're not contemplating surgery.
Isn't it? Here it is only palliative.
Yes, palliative.
It's not a neoadjuvant.
Terminology should be used very carefully, otherwise you'll get into trouble.
palliative therapy.
Most of the questions in the chat box has been cleared. So shall we conclude the session, madam, with the take home message?
Venkatachala left, is it?
No, madam, he's unmuted. He's muted.
No, it's Sir Arun sir asked him if he's.
I asked if you have any further inputs on this case.
Yeah.
It's fine. I
Maybe
think
he has
most of
just
it has been discussed. Probably we can conclude.
Yes.
Thank you so
So
much.
for the,
Thank you.
yes. So for the
Good, Akhil.
PGs,
Good presentation
for the-
from Akhil.
Thank you.
yes, ma'am. For the postgraduate, especially, there's a take-home message that do not please come to a final diagnosis in the history itself, especially when it is a neck of the abdomen mass. Abdomen is a Pandora's box, so you need to come at the differential diagnosis at the history. It is stressed enough by the examiners today, and there is always a differential diagnosis. So take a proper history and come to a differential diagnosis. And what we have seen is that PGs tend to know the diagnosis before only, so please do not do that. Okay, always put your insights into the history examination and then come to a diagnosis. It will be a better presentation that time.
Yes.
So our examiners today did an excellent job of putting this message forward. I would like to thank both our examiners for doing a wonderful job, and this postgraduates, Dr. Akhil and Dr. Chetana. Sir, I would hand it over to Dr. Sarvesh. Thank you, ma'am.
Thank you. Thank you.
Thanks to KSC, sir.
yeah,
Shanai, sir,
yeah.
thank you, sir.
So just a minute, just a minute. I would like to say just one or two things for the postgraduates only. The idea is just for you to help in your presentations, number
Yes.
one.
Yes.
The second idea is to expose yourself to different examiners, not from your college.
Yes.
Number three, to impress upon every time to you that, remember, we are in India, we are in our system of clinical examination. So please try to understand that who will be your examiners and what type of questions they follows. And don't go retro. Retro means what Dr. Shilpa just now said, that it is a case of dash, dash, dash. So you try to develop your own style of retro analysis. It is not that way. Okay. So you start with the examination, then proceed. That's how it is. History and all. So Chetana, her internet, some problem was there. So you look at that difference. Akhil's internet connectivity is quite good. I'm not blaming you, but just to be more effective in online thing, these are the things you have to keep it in mind. Yes, everybody should know natural behavior of the disease. That is one of the things you should know. And don't give a diagnosis of my anatomical diagnosis lymph node, pathological diagnosis secondaries, my anatomical diagnosis liver. No, that is for examiner to ask you. See, give an examiner chance. When you make a diagnosis of secondaries in the liver, examiner will ask you why liver, why secondaries. Okay. Similarly, for first case, you commit. See, when you say commit, that's what is your working diagnosis or establishing diagnosis. And second is always a differential diagnosis. So try to learn in that way. Okay. Yeah. So before proceeding, these are few things. Yes, there are many things to comment, but I am also recognizing Dr. Siddesh. Are you there? So
yeah, good evening.
Yeah, just say just few concluding, words or words of.
So yes. Nice of you. Thank you, Dr. Rajgopal Shanai, Chairman, and the office bearers, the convener of this clinical symposium, Dr. Shilpa, and all the faculty. I really congratulate the whole set of office bearers and the examiners who have done a wonderful job. I really appreciate the Karnataka State Chapter having taken up this teaching sessions, which is exclusively meant for postgraduates on one of these Thursdays, second Thursday. And then, of course, what is in general for every surgeon on fourth Thursday. It's a really novel idea. I wish all the postgraduates get hitched onto it and get an advantage out of it. I really appreciate, because Rajgopal being a teacher of teachers, and he is really a good clinician by himself. So he has stressed upon this particular aspect of clinical science, which is often now rarely felt. We are losing out this importance of clinical science. So more than passing the exam, I feel this session will help students to understand the importance of clinical science. So recently, again, I appreciate Dr. Kalaivani being stressing the fact that we should learn to interpret ourselves the images, and not only images, even the lab results. Don't go by just 1 or 2 parameters and conclude the diagnosis or come to a conclusion. Always try to try to evaluate each one of the biochemical parameters have a value to add to your clinical science. Same way the imaging modalities. Don't just read. I've been seeing more often, even my assistants now who are qualified surgeons, they just go by the final impression in the scan or CT scan. Don't read those lines first. Try to interpret yourself, because you are the person who is treating the patient. You know the clinical science. Just to give an example, recently one of my uncle, 85-year-old, he got an acute cholecystitis. You know, by and large, by protocol, we get a CT anybody above 70. So there was no stone seen on the CT. But clinically, we know there was an empyema of the gallbladder. We sat with the radiologist. We discussed. We found a suggestion of a stone impacted in the neck of the gallbladder. And I will tell you, today we did an empyema with a stone impacted in the cystic duct, which was picked up because we could go and sit with. So because 85-year-old, we should always think possibility of a CAGB. So clinical science is most important. Similarly, again, we had one more cholangiocarcinoma, lady, 70 years, proximal duct dilatation seen, distal CBD normal, no obvious lesion. Query mirisi is radiologist doesn't know the correlation. There are stones, but we went and saw that stone is nowhere near the duct. So it is not there is incidentally stones are present. We need to think of if there was a case of cholangiocarcinoma diagnosed later by MRCP. So your clinical knowledge is most important, and you should go and read your images yourself to have a best of interest of the patient and your own patient management. So with this, I really appreciate again our chairman having taken up this task of organizing this. This is not an ordinary job. To organize every month one meet is also a very difficult job. And I appreciate all of you who have joined in to help him in contributing to this. And I thank you again, and all the best to the future as well, Karnataka State Chapter. Thank you.
Yeah, I think without wasting much time, we will, Dr. Sarvesh, please. Yes.
Yes, sir. As our seniors said, the teachers and teacher of teachers, see, don't lead the examiner to know that when you know the diagnosis already, though you know it. This is the take-home message today. Now I request Dr. Gurubasan Goda to deliver the vote of thanks.
Thank you, Dr. Sarve, sir. First of all, I thank all the participants for actively participating in this clinical session. And I thank Professor Rajgopal Shanai, sir, Dr. Sarvesh Raj, and of course, examiners, Dr. Arun Kumar, sir, Dr. Kalaivani, madam, moderator, Dr. Shilpa, past national president, Dr. Siddesh, sir, and national GC members, Shivram, sir, President-elect Dr. Naz, madam, and other HODs, EC members, students, and of course, Madhu Pandian, sir, just came for a short time and he left it. Thanks for you, sir. Thanks for all joining this session, for inculcating lots of knowledge to the young students, budding students, in helping and shaping their futures. Thank you, everybody. Thank you. Thanks a lot, and good night.
Okay. Thank you.
Thank you. Good night. Good night.
Thank you.